symptom complex of agitation and breathlessness in COVID-19. This session will be taken by Dr. SHOBA NAIR. Dr. SHOBA has done MBBS and MG from India and MRCP from Edinburgh, and then did MSc in palliative medicine from Australia. Currently, she is working as the professor of palliative medicine at Amrita Institute of Medical Sciences, and she is also doing her PhD in palliative medicine from Lancaster University from UK. Welcome, madam, and it's over to you.
Thank you, Sunil. Good afternoon, everyone. Again, apologies for the delay in starting the presentation. Okay, so today we're going to deal with managing the symptom complex of agitation and breathlessness in the context of COVID-19. Okay. Okay, next slide. Okay, so what are the learning objectives of today's presentation? So one is assess the rate and severity of breathlessness in COVID-19, identify agitation with and without delirium, management of both symptoms, familiarize with use of algorithms of both symptoms, and discuss other effective management techniques. Next slide. So how do COVID-19 patients present? Next, the first category is least serious, which is subclinical. It has the virus, but they have no symptoms. These people have the virus, but they have no symptoms. The next category is upper respiratory tract infection, fever, cough, milder symptoms like headache or conjunctivitis. And these people are able to transmit the virus. And the third one is flu-like symptoms. It usually keeps people off from work. When we have flu symptoms, we don't tend to go for work. And these people present themselves to the hospitals. This is the third category. And the fourth one, we have severe illness that features pneumonia. Next slide, please. So, COVID-19, the role of palliative care, it has been published several times, several journals. So one article from Italy, it was published by consultants who actually saw people and converted the emergency admissions unit into an end-of-life care area. So what they have said is, the next slide, is it is an ultra-emergency situation. This is the difference between the normal palliative care and palliative care for COVID patients. Ultra-emergency situation, no relationship with the patient and family, no typical palliation timing for sharing and planning the treatment path, and deaths are linked to traumatic psychological experience for the family and members of the treating team. Just a minute, just a second. Just a second. Right, let's go back to the third slide, please. Let's go back to the third slide. Let's go back to the third slide, please. Thank you. Right. Thank you. Okay. The next slide, we'll just quickly look at pathophysiology and staging, just one slide, in which they have divided it into stage 1, 2, and 3. The first stage, which is the early infection stage, has got clinical symptoms and signs which are mild in nature. Clinical signs, lymphopenia, increased prothrombin time, increased D-dimer, and LDH. And stage 2, which is the pulmonary phase, is divided into 2A and 2B. And it progresses to hyperinflammation phase, which is stage 3. So in stage 2, there is shortness of breath, hypoxia, abnormal chest imaging, transaminitis,
Hi,
low
doctor. I
normal
slide
calcitronin.
is different.
Hello?
Yes, please continue, madam.
Okay. And the third stage is ARDS, SIRS, shock, cardiac failure, elevated inflammatory markers, CRP, LDH, interleukin 6, etc. I think you're not moving the slides. The pathophysiology and staging is the next slide, please. So that's what I'm talking about. Sorry, I didn't say move the slide. Okay. So this is the host inflammatory response phase, which is stage 3 that I was talking about. This is from the Journal of Heart and Lung Transplantation. Okay, and they've written about potential therapies, which includes chloroquine, hydroxychloroquine, remdesivir, etc., which we're not 100% sure whether they work or not. Okay, so there is a cytokine storm kind of a phase in hyperinflammation phase. That's what we need to look at in severe breathlessness. Next slide, please. So this paper, which was submitted from some province in China, in Annals of Intensive Care, they have shown that age, lymphocyte count, oxygen inhalation, the CT scan findings, etc., are detrimental, and we need to monitor that. And if it's high risk, that means lymphopenia, high age group, etc., are high risk, and they need continuous monitoring. The other is low risk, and screening twice every day is sufficient. So respiratory rate of more than 30 per minute, or SpO2 less than 93%, or heart rate more than 120 per minute. Then patients go into critical care management. Next slide, please. So this, I think I mentioned before, this is an article from Italy in which they have redefined the role of palliative care physicians. And they have found that, next slide, please, ultra emergency situation, no relationship with the patient and family. Please keep pressing. No typical palliation timing for sharing and planning the treatment path. Deaths are linked to traumatic psychological experience for the family and members of the treating team. So we all know that we take a lot of time to have a rapport with patients, talk to them, make them feel comfortable. We really don't have time in this particular context. And it's extremely difficult to deal with such a situation. Next slide, please. So let's talk about breathlessness, which is the first symptom that we're going to talk about today. Look at this X-ray. Next slide, please. So you can see that, you know, when you look at it quickly, we'll see, oh, we'll feel that it's a normal X-ray. But if you carefully, you can see that the lower lung marking have become coarse, and you can see them clearly. So there's an early sign of something happening in the lungs. And another CT finding, it shows hazy patches in the outer field of the lungs. Next slide, please. Okay, in the CT scan, you can see the hazy patches in the outer field of the lung. Okay, so there's a clear sign of pneumonia in this scenario. Don't have to actually wait for this, for the patients to be treated, is what we would say. Okay, next slide, please. Breathlessness in COVID patients. What are the contributing factors? So we already talked about the complex pathophysiology, in which there is a cytokine storm, and there is, contributing factors when you're in the vulnerable age group, especially the elderly and with comorbidities. Anxiety, because there is a information loading which is happening at the moment with no definite treatment. And isolation. The people who come in, they are isolated from their family members, as we all know. So there's a lot of anxiety which contributes to breathlessness. Other psychological and social issues are guilt. Okay, did I do something wrong? Did I go out and then contract the disease, or did I spread to others? Anger, that this is happening to me. I took all precautions and this again still happening to me. fear what's going to happen to me next, and the loss of income that the patient or the family is going to have. So all these factors contribute to breathlessness in COVID. Next slide, please. So coming to the management, we have to follow the COVID-19 management protocol. There is no clear-cut guidelines on this. I think it's individual geographical practice. There are broad guidelines, and people choose and pick what suits them at the moment, because there is no clear-cut evidence to the efficacy of all these medications that we have listed earlier. So just for wanting to do something, and since we don't have any medications, a lot of different things are being tried. So correct the correctable factors. Obviously here what we need to think about is we don't have pleural effusion so much in these patients, and so there's no when we talk about correct the correctable, pleural effusion is one of the major things that we can correct and reverse it. In COVID-19 patients, that's not the case. And treat bronchospasm if present. Yesterday we were talking about, okay, we probably would not advocate nebulizers, but MDIs, metered doses, inhalers, are the ones that are advisable in these patients. Next slide, please. So what is the evidence for management of breathlessness in COVID-19? So this paper, looking at managing the supportive care needs of those affected by COVID-19, I would like to bring to your attention that one of the authors is Andrew Wilcock, who is the author of Palliative Drug Formulary. So these are all guidances. There's no, like my colleague said earlier today, that these can't be called guidelines. They are guidances, which people have put forward from their clinical experience and what we have tried in other patients. So this is one of the guidance. Next slide, please. So the next one is the NAIR guidelines, which was published a couple of weeks earlier, 10 days ago, 3rd April, yeah, okay, 15 days ago, managing breathlessness. So next slide, please. So what does this management comprise? Okay, the patient is in the ward. What are the non-pharmacological measures that we can do? Mind you, the patient has not gone to ICU. The patient is in the ward. So what can we do to allay his fears and make him comfortable? Definitely positioning, relaxation techniques, breathing techniques, cooling the face. Here, normally when as palliative care professionals, we always advise about fans being used in the room, handheld fans, etc., which is not the case with these patients, as you would know, because of aerosol generation. So tepid sponging with cool towels, etc., on the face might give them some sort of relaxation. Next slide, please. Okay. Next is the pharmacological management. In the ward for mild to moderate breathlessness, you don't need to worry about the different doses and things like that. I'll just read through it. You can always look back and look at your clinical practice in your area, and it differs. So the medicines that we use are morphine and midazolam, because there is a lot of anxiety contributing to breathlessness. So morphine, 2.5 to 5 milligram per oral every 4 hours. Midazolam, 2 to 5 milligram every 4 hours, slow IV or subcutaneous. Or lorazepam, 0.5 to 1 milligram sublingual SOS can be given. Continuous infusion of morphine, 10 milligram, and midazolam, 10 milligram intravenous or subcutaneous over 24 hours can also be started in these patients. Next slide, please. So when the patients have severe breathlessness, that's when people are being shifted to ICU. And sometimes even without severe breathlessness, when other parameters don't look too good, and if there are some tests being done looking at the natriuretic peptide, etc., when there is cardiac functions which are deteriorating or other parameters, then patients get transferred to ICU. So what are the non-pharmacological measures as appropriate to ICU settings? At this juncture, I would like you to pause and think for a minute. In your ICU settings, what are the normal non-pharmacological measures that you would use in your ICU settings, in your hospitals, in your countries? And please make a note of it. You can put it in the chat box, which we can see later. Okay, next slide, please. Next slide, please. All right, okay. So in ICU also, they might have mild to moderate breathlessness, for which we can always give morphine or fentanyl. Earlier we were giving 4th-hourly, here we could give 2-hourly with midazolam or lorazepam, or we can continue infusion of morphine 15 milligrams of fentanyl 100 micrograms and midazolam 10 to 30 milligrams intravenous or subcutaneous over 24 hours. Okay, so this is before the ventilation bit is what we are talking about. Okay, the patient has gone to ICU, but again, there are measures are continuing to control the breathlessness and calm the patient down. Right, next slide, please. So there is significant breathlessness towards end of life. So we've talked about at this juncture, I think it goes without saying that when you have breathlessness, and if the patient has lived his life fully, like yesterday we were talking about an 81-year-old gentleman, Dr. Rajashree was mentioning about that patient, who we can imagine coming in, who had a good quality of life, but is actually deteriorating. And definitely we need to consult him. If his performance status is good, then he would obviously like to go to get the ventilatory support. But there are people with comorbidities who wouldn't want to go to for ventilatory support. It's so difficult to decide at this juncture because they are not even able to consult the relatives. Of course, a triage team can always contact the relatives and ask for an opinion if the patients themselves can't give an opinion. And suppose we go into the ventilatory bit, yes, of course, we go that pathway. I think triaging, Dr. Moira Leng would be speaking to you in the next coming days. So we're going to talk about people who do not opt for ventilation with significant breathlessness towards end of life, with respiratory rate of 30 per minute. Okay, so morphine 2.5, fentanyl or fentanyl 25, midazolam 2.5 can be given every 15 to 30 minutes till improvement of symptoms. The patient calms down, till the patient calms down, we can give this. Or simultaneously, you can start a continuous infusion of morphine, 30 milligrams, of fentanyl, 150 to 300 micrograms, and midazolam, 15 to 60 milligrams intravenous or subcutaneous over 24 hours. This can be started. Next slide, please. So generally, we were talking about mild to moderate breathlessness in the ICU and outside the ICU setting, difference being the frequency with which we administer medications and the amount or the concentration or the strength of the medications that we would put in for continuous infusion or SOS infusions. So this algorithm is given in the e-book, which you all can have a look. We've just put it there so that it reminds you to look at the algorithm. Okay, so what is the take-home message? Morphine is a useful drug in relieving cough, breathlessness, providing added symptom relief and quality of life. Judiciously administered morphine will not produce respiratory depression. Morphine can be administered by multiple routes, orally, intravenously, subcutaneously, and even rectally. And consultation with a palliative care specialist can be complementing in ensuring symptom relief. So that's with breathlessness. What about delirium and agitations? Why are we talking about breathlessness and delirium and agitation together? Because these patients have, because of hypoxia, they have delirium and agitation. And because of agitation, they can have breathlessness. So that's why these symptoms are clubbed together, especially in COVID-19 patients. So imagine, again, next slide, please. Imagine again a patient, our 81-year-old gentleman who's coming to the hospital. Next slide, please. Coming to the hospital, is getting examined by the healthcare team in a busy admissions area. Mild anxiety is present. Contributing factors, as we said earlier, away from family, worried about what's in store, dyspnea. And the dyspnea worsens with hypoxia. Patient becomes restless and anxious, but the patient is oriented. Maybe the next day the patient becomes disoriented and becomes agitated. Okay. So there are two areas that we can intervene and make the patient comfortable. Next. Okay, so that's one area where the patient is restless and anxious and oriented. And the next one is the patient is agitated and disoriented. Next slide, please. So how can we actually assess whether the patient is anxious and agitated, or the patient has become delirious and agitated? The problem with delirium is they might have lucid intervals in between. And if we actually assess during that lucid interval, and if the patient behaves normally, alert, answers your questions, then we might be thinking, oh, he's just anxious, and then we might go a different route of medications first. Although there's only a couple of medications that we give in agitation, we need to be careful that the patient is not delirious. Okay, so what can we do? This is a quick tool which is called the 480 delirium assessment tool, which has got 4 A's in it. The first one is alertness, normal, fully alert, 0, mild sleepiness, 0, clearly abnormal, 4. And the other one, second one is AMT4, which is the abbreviated mental test, 4, in which the patient is asked about age, date of birth, name of the hospital or building, and current year, which is a normal question that we would ask anyone who would come. The third one is attention. It's a little difficult whether we can apply this in a COVID kind of scenario is anyone's take. Okay, here to test the attention, people are asked to sort of narrate the months backwards. So December, November, October, like that. So starts but scores less than 7 months and refuses to start, is the score is 1. 7 months or more correctly, sorry, that is 0. And untestable is 2. The fourth one is acute change of fluctuating course, in which there is evidence that the patient is behaving in a different manner in the last 2 weeks and still evident in the past 24 hours. Now, this is going to be extremely difficult. We don't have anyone to ask, and we might have to call people up where they came from. And sometimes they are in a home quarantine. Not many people would have noticed what their problems were. Or it might be difficult to elicit that kind of a history. I'm just stating. Okay. So this tool can be administered by any untrained personnel. It can be administered in less than 2 minutes. So that is why it is used. Although it is written more, above 65 years, it can be applied across age groups, is what the literature says. Okay, 4 or above, possible delirium, use of delirium pathway. 1 to 3 is possible cognitive impairment. 0, delirium or severe cognitive impairment is unlikely. But delirium is still possible if 4 information is incomplete. That means acute change of fluctuating course. If we are not sure of that, then delirium is still possible, is what we say. Okay, next slide, please. So what is the evidence for management of agitation, delirium in COVID-19 patients? Again, we have the NICE guidelines. Next slide, please. Next slide, please. We have the NICE guidelines. Next slide. Yeah, this is the German guidelines in which they have come up with their own recommendations. And what they have said is, you need to look at other causes of restlessness and anxiety, as has the next slide, please. Sorry, I'm changing from my side. The CAPC, the Center to Advance Palliative Care, has also come up with. So what they've said is, don't forget to look at constipation, urinary retention, pressure ulcers, etc. People who are normal already palliative care patients who are bed bound, they might be coming in with COVID-19 infection. So you cannot forget those kind of basic contributors for agitation, is what they're saying. Next slide, please. Okay. The contributory factors for anxiety, agitation, and delirium. One is definitely breathlessness. The second one is pain. I think we talked about pain yesterday, and the universal drug being morphine, which would help with breathlessness and pain. And especially in elderly patients, we should not forget to ask for urinary retention, constipation, etc. The patient might already be on morphine, and we're increasing the dose of morphine, they might have urinary retention. Okay, but in young patients, especially young patients, holds good for old people also, but in young patients, we should never forget to consider withdrawal syndrome. People who are used to taking alcohol, there might be substance abusers in that group with COVID-19. So we need to look at them as well and take that history. Next slide, please. So what is a management? Healthcare professionals should be calm. Next, should be calm, capable, and compassionate. Next, responsiveness is a major thing. I think optimal response is required from healthcare professionals. What does optimal response mean? Just being calm and composed and actually addressing their problem. Okay, reassuring them. So that's going to come next. So start a gentle conversation. Next, reassure the patient. Next, keep the room airy and lighted as much as possible. Next, ask if they want to convey a message to their family and encourage them to ask any questions that they might have. So you should always be welcoming to their queries. Sometimes we are in such a hurry that we don't entertain questions from people, even in our routine clinical practice. So that should not be the case. And like my colleague, Dr. Biju Raghavan said in his communication skills, I think that's going to come next. We are in our PPEs and people can't see our faces, and you can always stick your names right in front of you in big letters. You're so and so, and we're here to help you. That kind of a thing, which would help them. And also, he said something about smile in your voice. Okay, so the gentleness with which we look at people, with maybe smiling eyes, and the smile and in your voice, and the calmness that you show to these patients go a long way to comfort them. Next slide, please. Okay, so management of agitated and oriented patients with anxiety, panic, or fear. If it's mild, if able to swallow, lorazepam 0.5 milligram to 1 milligram twice a day, oral or sublingual. Oral tablet can also be used sublingual. In India, we don't have specific sublingual tablets, so we use oral tablets itself. Or clonazepam 0.25 milligram to 0.5 milligram twice a day. Next, if not able to swallow, then injection midazolam. Next, 2.5 to 5 milligram bolus injection and SOS. Next, please. Right. So injection midazolam if the patient is not able to swallow. Next slide, please. So moderate symptoms, if agitation persists, a continuous, we've given all the things that we discussed in the previous slide. And even then, if the agitation persists, a continuous IV or subcutaneous infusion with 10 milligrams of midazolam in 24 hours can be given. And if the symptom persists after starting the above infusion, add injection haloperidol. So remember, here is a patient with anxiety, panic, or fear, but the patient is oriented. We have started benzodiazepines first, and then we have added in haloperidol. 0.5 milligram every 15 minutes SOS, or 1.5 milligram to 5 milligram in 24 hours. Next slide, please. So in agitated and disoriented people, that means this patient has delirium, we start injection haloperidol first. 1 milligram slow IV or subcut, or 1.5 milligram per oral, may be repeated every hour up to a dose of 5 milligrams. Or a bolus injection of 1 milligram haloperidol can be given intravenously or subcutaneously, and a continuous infusion of 5 milligram haloperidol can be started simultaneously. So you can give an injection of 1 milligram haloperidol and start a continuous infusion simultaneously. Next slide, please. If it is moderate, agitated, and disoriented, if agitation persists, add injection midazolam, 1 milligram slow intravenous subcutaneous, and repeat every 10 minutes till the patient becomes quiet. Or a bolus injection of 2 milligrams midazolam can be given intravenously subcutaneously, and a continuous infusion of injection midazolam, 10 milligrams, can be started along with injection haloperidol. So we started injection haloperidol first, and then we added in midazolam. Next slide, please. So intractable agitation and delirium, if symptoms persist, a maximum dose of injection haloperidol 20 milligrams and injection midazolam 30 milligrams can be given as a continuous infusion in 24 hours. So especially Dr. Raj Gopal, he has a lot of experience with using injection haloperidol up to 20 milligrams. In other countries, sometimes this is not the case, but you can follow your own principles. But in case you see severe agitation, we have experience in using injection haloperidol up to 20 milligrams. Injection midazolam, we have written 30 milligrams, but we can go up till 60 milligrams if we are used to prescribing that dose. They can be given as a continuous infusion in 24 hours. Remember, we can combine this infusion in a single syringe driver, and it can be given. So these are compatible medications. Morphine can also be mixed with this. So in a syringe driver, there are 3 medications that can be mixed at a given time. So morphine, midazolam, haloperidol can all be mixed together, and they are miscible. Next slide, please. So this is again showing the algorithm that we've created in our ebook, which necessarily says the same thing that we've discussed so far. Just remind you that you can always go back to that ebook and have it, and refer when it is required. Next slide, please. So in summary, for agitation and delirium, so please keep pressing. Since I'm not controlling from my end, you could do that. So there might not be enough time to recognize agitation and delirium. Next, 480 delirium assessment tool is quick tool to use. Next, remember to treat pain with paracetamol and morphine. Next, remember to ask for possible withdrawal, treat and refer appropriately. Suppose you're thinking, okay, now this is not only anxiety, agitation, the cause of the infection, and we're seeing clear withdrawals in symptoms, delirium tremens, those kind of things. And if you're not in a position to treat them yourselves, you can always take your colleagues' help. Call the next psychiatrist or a general medicine physician who always used to treating these people. So chlordiazepoxide, diazepam, or narcotics need to be given. For anxiety and restlessness without disorientation, start a benzodiazepine. For restlessness, agitation with disorientation, start an antipsychotic. Haloperidol is the easiest injectable antipsychotic that we have. So that's why we put haloperidol there. Next slide, please. So thank you for listening to this talk, and we're open to discussion.
Thank you, Dr. SHOBA. And the session is open for discussion. There were some chat questions. One was about how can fentanyl and morphine reduce breathlessness? They are analgesic as well as sedatives. That was one of the questions.
Oh, all right. Okay. So, morphine especially, if you look at CCUs, when people have cardiac failure and, in myocardial infarctions, of course, the first choice of drug is injection morphine for chest pain. But for pulmonary edema, again, the drug of choice that we give as an IV infusion sometimes is morphine along with diuretics. Now, so how does morphine help with breathlessness? Different mechanisms. One is it reduces the respiratory rate, and we're not giving a dose which would inhibit respiration, but it would stimulate the respiratory center and keep it moving. But it will calm the patients. That is one mechanism. Second mechanism, it has got vasodilatory properties. So if the heart has to pump against a force which is not tolerable to the heart, remember there is a back pressure from the lung, okay, where the lung is compensated here in these patients, and the back pressure is again going to the heart. And if the heart has to pump against a forceful vasculature, that's going to add on to the breathing workforce. So the people will have to actually put in extra work to actually breathe. So this is dissipated by giving a vasodilatory morphine. So the vasodilatory property is the one that helps in reducing breathlessness here. And also it reduces pulmonary edema because it paves the way for getting all the fluid out of the lung by vasodilatory property. So again, diuretics also help in the same manner.
Okay, another question is on can we use 4-80 tool in elderly with dementia?
Okay. Can we, sorry, say that again?
How to use 480 tools in elderly with dementia.
For 480 tools, that's extremely
Yeah.
difficult. That's extremely difficult. So if the patient has dementia, again, it will help us to sort of, talk to the relatives over the phone, the tried system like that I was talking about. You can talk to them and say, okay, the patient comes in with a history of dementia. It's very difficult to get that history quickly from the patient themselves. That's going to be difficult. So if the patient is demented and whether the patient is delirious or not, that is $1 million question. It's extremely difficult to understand whether that's delirium or dementia. But you can always go in and ask them about. You can assess their alertness, their whether it was changed. You can always call up their people and ask whether there was any change in the recent times. I think there are psychiatry consultants here in this room who are also palliative care physicians. If they want to add something to this, that might be helpful. Dr. Chitra Venkateshwaran.
Thanks, Shobha. I think it is, as you said, quite challenging to diagnose delirium when there is a history of dementia. But of course, as you said, we should talk to the family members. So you know that there is a history of dementia. Dementia is not an acute presentation. It will have a history of a few years of deterioration in terms of memory and other functions. But even then, we can actually quickly assess the higher mental functions of disorientation and the fluctuating level of consciousness, which is not seen in dementia.
Right.
So the disorientation function, the orientation function, and the level of consciousness is actually very stable in dementia. Dementia, usually, it is a memory which is impaired. So in delirium, it is an acute fluctuating level of consciousness, which is very evident. So if you use those which are specific for those functions, and of course, it's an acute presentation in these patients that we are going to see. So you would see a very florid kind of presentation, which will not be actually dementia, but a delirium superimposed on dementia.
Right. Thank you, Chitra.
Okay. So the next question is, how do you choose between lorazepam, diazepam, or midazolam? What are the pros and cons of each when using in delirium?
Right. Okay. So in delirium, of course, we would like to use short acting rather than long acting, definitely. So midazolam would be a good choice. You know that it works for 1 to 2 hours, short acting midazolam. And then comes lorazepam. So especially in Western countries, people are used to giving sublingual lorazepam all the time. They give it every 4 hours, every 6 hours, and it goes on like that. Sometimes even more frequently. The hours in between are much less. So here, if the patient is not able to swallow, definitely we go with midazolam. And diazepam, it's a little tricky because the patient can be drowsy the next day, continue till the next day. So midazolam, lorazepam would be a good choice. Very small dose of diazepam if the patient is really agitated and you're not able to control with other measures, then of course you can go in with diazepam. But we do keep that as a last choice. Definitely midazolam the first choice. The patient is oriented, can take orally. Lorazepam can be tried, even clonazepam. Again, clonazepam is longer acting than lorazepam. So clonazepam, if the patient, we start always with an HS dose, but in these patients, when they come in quickly, we can always give it immediately. Lorazepam is available, that would be the drug to go with. And then clonazepam. The injectables, midazolam.
Okay. So there is one more question regarding what will be the management of pediatric patients. I think this applies to both symptoms, agitation as well as breathlessness.
So in my practice with children, in normal palliative care consultations, what we do is definitely follow the guidelines. And there are certain changes which we make as far as different drugs are concerned. But midazolam, diazepam, etc., can be given to children. Morphine definitely is the drug of choice that you can give to children. So you need to look at their age group, their body weight, and then calculate the dose. Get the help of a pediatrician and do that. Tramadol is not a good choice, although we haven't listed here in this presentation. Sometimes for pain, that is an easily available medication. You can pop in, and that controls myalgia, etc., experienced by COVID-19 patients. Tramadol, definitely we don't use that much in kids. We can use it in older kids, but in young children, definitely morphine is a drug of choice, midazolam and haloperidol. Do you want to add anything else, Chitra, for agitation or delirium?
Agitation and delirium, I think, I mean, what did you mean by, I mean, we're talking about tramadol.
So, yeah, no, tramadol we don't give. We give.
Yeah.
Definitely, midazolam can be given. We can give haloperidol.
Morphine would
there
be
is no other. Yeah.
Morphine and the regular,
Yes.
and small
That's
dose of haloperidol if there is disorientation and confusion.
Yeah.
In younger age group, haloperidol is very well tested. So it's been a drug which we are used to for a long time. So better to use drugs that we are comfortable with.
Yeah. Exactly. So pediatrics, with the dose adjustment and weight adjustment, you could use the same kind of modality. And actually made the guidelines for pediatric age group so far, since COVID-19 doesn't seem to attack kids so far, although there are sporadic reports. Kids get.
Okay, Dr. Moira?
Thank you. Such an interesting presentation and discussion. I just wanted to maybe help us remember what Dr. SHOBA told us, is that there's a symptom complex which is combining agitation and breathlessness. And so in that circumstance, it's more of the anxiety and fear that goes along with air hunger and struggling to breathe that we need to think of in advance and be ready for. Of course, then we have all of the skills that Dr. Chitra and others were describing of how we manage the acute confused patient who's not necessarily in that acute symptom complex. So we can try and make sure we're ready for the patients with COVID-19 that may deteriorate rapidly, and we need to think in advance how we manage this major symptom, as well as applying all our excellent medicine that I've been using.
Thank you, Moira.
Okay, so there is one more question regarding breathlessness. This morphine will cause vasodilatation that will help in pulmonary edema or MI. But in COVID patient cases, it is respiratory cause or issue or anxiety. So benzodiazepines are better than opioid. That was one.
Sorry.
So morphine will cause vasodilatation that will help in pulmonary edema or MI. But in COVID patient cases, it is respiratory cause or anxiety. So benzodiazepines are better than opioid. That was one of the comments.
So yeah, even in COPD patients, especially when you go towards the end stage, what happens is there is, of course, it is connected to the right side of the heart, the pulmonary artery, etc. And you can have something like cor pulmonale, which causes right-sided heart failure, which can lead to congestive cardiac failure. The same thing, I'm not saying exactly the same thing happens, but here there is a discussion about ARDS, which is a cause for the respiratory problem here, or they are saying it could be something like that happens in high altitude, because of the lack of acclimatization, suddenly everything collapses. So in this also there is a cytokine storm, and there is a lot of alveolar shutdown, and there's a back pressure, which is nothing is happening into the back pressure into the blood vessels, which causes breathing difficulty. So definitely morphine is going to help in this condition, as it progresses.
Okay, I would like to add something to that. The stimulus for breathing is carbon dioxide. So when there is more carbon dioxide, that is hypercapnia, we will start in an increased rate. So morphine reduces this hyperventilator response to hypercapnia, so that the respiratory rate will be reduced. And in addition, the morphine also causes sedation of the cortical center. And we have to understand that breathlessness is a feeling, so that feeling is also reduced in addition to the pulmonary vasculature dilatation and better perfusion ventilation ratio. So these are the additional effect of morphine, how it will reduce breathlessness.
Thank you, Sumit. Any other questions?
So is there any dosage for haloperidol based on weight?
Based on weight?
Yeah. Weight of the
No,
patient.
yeah. So we don't normally in a clinical practice we don't use in that manner because the small doses are given, and we start with small doses and then build it up to control the symptoms. So it's basically based on the symptoms rather than the weight. It's only with young children maybe we would look at weight. But if we know that suppose a cancer patient who's really emaciated, anorexic, cachexic, gets COVID-19, obviously, and if the patient is going into the terminal stages, then we would be careful not to push the patient over the brim. With haloperidol, of course, you're not going to do that, but we would still be careful with the dose. We start with 0.5 milligram and then go up. But generally, we don't look at weight for haloperidol.
Thank you, madam. Any more questions or comments? If you have any comments, you can unmute yourself or you can raise your hand so that we can unmute you. Anybody? Dr. Bigas? Yes, Dr. Bigas Anand.
Hello. I just want to ask about the intractable agitations with the delirium. Dosing which we have just talked that injection haloperidol 20 mg along with the injection midas 30 mg can be modified dose or it is a fixed dose to be given in infusion.
Sorry, whether the 6 doses can be given as an infusion. 6 doses can be given as infusion. You're asking.
I think what he asked was whether this is a fixed dose or is it flexible?
It is flexible, definitely. What we put there was the maximum dose that you can give, just a guideline. You can make your own clinical decision looking at the patient and decide on what is the dose that is appropriate for this particular patient according to the symptoms. Okay, I gave him 2.5 milligram as an SOS and he's comfortable for how long? You can always calculate that. Here, like, we don't have the luxury of actually looking at what were the doses that were taken in the last 24 hours. We might not have time. So you need to look at the next few hours, how the patient is faring. Like I said, every 15 minutes you can give an injection in the presentation that was told. So these doses are not fixed. You can always choose to what the dose that you would like with your clinical experience, talking to your peers, talking to your seniors, looking at guidelines, and coming to a consensus. Take a team decision and decide on the dose.
Thank you.
Any more questions? Dr. Moira was asking, can you recommend the essential medications that are must-haves for COVID-19 breathlessness and agitation?
The essential, you want me to say that now, Moira? Is that what you meant? The essential medications, I think that's what you meant, yeah. So the essential medications, definitely for breathlessness, agitation, and delirium are morphine, midazolam, and haloperidol. We are talking about people, who are much more comfortable with injections rather than oral medications. That would be safer. So this if medications are there, if you're prepared, okay, your hospital is going to receive some of these patients, and if we know, okay, all these medications are available in your emergency tray, or in your ward where these patients are going to get admitted. Whether they have mild, moderate, or severe symptoms, we need to be prepared. So definitely, these are essential medications that need to be in the area where COVID-19 patients are going to get admitted. That is, again, morphine, midazolam, haloperidol.
Any more questions? Okay, and Dr. Sandeep has written that when using haloperidol and hydromorphone together, be cautious.
Yeah, so we don't have hydromorphone here in our country. Oxycodone, hydromorphone, etc. We don't have in India. Definitely morphine, yes, it increases sedation. And haloperidol, the side effect that we would look at would be QT prolongation and obviously the extrapyramidal side effects, which we really don't have time to look at in this scenario. If it is going to be end of life, then we are not going to look at the QT prolongation in this particular instance. There might be other medications, for example, other cardiac toxic drugs which are being given to the patient, like hydroxychloroquine or azithromycin, that can, a macrolide that can prolong the QT interval. So we need to take it with a pinch of salt and see like what is required for the patient, what is the goal of care for this particular patient, and then look at it. I'm not saying that we shouldn't be aware of it. We need to be aware of it. We need to be careful. And in Western countries, they use methadone. But in this scenario, I don't think they're going to use methadone. Again, that is another drug that will prolong QTC, and it's very difficult to titrate and bring it to the required half-life in the blood for these patients. So methadone probably will be out of question. So if you look at all the different guidelines which is put around across the world, it's only morphine, which is easy to titrate. So the QTC prolongation doesn't happen with this kind of medications. Hydromorphone, we don't have it in our country.
Haloperidol will actually be useful with morphine in small doses, according to me.
Yeah.
Okay. So I don't see any more questions from anybody. So I think we can wind up this session. So Dr. Shoba talked mainly about two symptoms which may occur simultaneously in patients with COVID-19, breathlessness and agitation. Agitation may be with orientation or without orientation. And breathlessness can be treated in refractory breathlessness. It can be treated with morphine. Otherwise, the patient may also need the patient will undergo treatment of COVID, and bronchodilators and any other correctable causes has to be corrected. Along with that, morphine will help to reduce breathlessness. And according to the severity of breathlessness, we can change the dose of morphine. Agitation, if the patient is agitated without with orientation, then benzodiazepines would be the better choice. But if the patient is agitated and disoriented, that is in delirium, antipsychotics like haloperidol would be a better choice. Benzodiazepines can be added to the antipsychotics if the agitation persists. So thank you, Dr. Shoba, for your wonderful presentation, and thank you all for your active participation. We'll see you tomorrow at 3 p.m. With another topic on COVID-19. It's communication, taken by Dr. Biju Raghavan.